Good morning, Terence. You can hear me, right?
Yes, I can hear you.
All right, thank you.
Yeah. So can you see the video playing?
Yes, it's going on. Yes.
Okay, great.
Fear. Right now, there is a lot of fear because of COVID-19. People are scared of leaving their homes, scared of shaking hands with humans, and scared of going to hospitals because that is where COVID-19 patients go. So even if we need to see a doctor, we stay at home, and sometimes waiting could make things worse.
When news of COVID-19 spread, people stop coming to the hospitals. Even if they are not infected by the virus, they become infected by fear.
But did you know that hospitals may be the safest place in the world right now? When they started admitting COVID-19 patients, they had isolation rooms and special wards for these patients. One ward for COVID-19 patients, separated from the rest of the hospital, leaving the rest of the hospital safe for everyone else. So every time a COVID-19 patient walks in, they get dedicated nurses to take care and support them.
Safety is our #1 priority all the time. This helps to keep not just our staff, but also our patients and the general public safe.
They have doctors that specialize in infectious diseases, separate security 24/7, separate disposable cutlery, and even separate air ventilation systems to make sure even air doesn't go to other parts of the hospital. This separation is vital to keep everyone safe because for all other patients, it's the new norm. Many people still need hospitals, especially when they have worrying symptoms like chest pain, vomiting, or sharp pain in the stomach that need urgent medical attention.
Because of our very strict protocols and safety measures, our hospitals are safe, and that is a fact.
Because everyone, from senior management to doctors to nurses to security guards to chefs, is doing the impossible to keep the hospitals safe for you. So, only if you need urgent medical treatment, stay home, be safe, and keep healthy. Fear. Right now, there is a lot of fear because of COVID-19. People are scared of leaving their homes, scared of shaking hands with humans, and scared of going to hospitals because that is where COVID-19 patients go. So even if we need to see a doctor, we stay at home, and sometimes waiting could make things worse.
When news of COVID-19 spread, people stop coming to the hospitals. Even if they are not infected by the virus, they become infected by fear.
But did you know that hospitals may be the safest place in the world right now? When they started admitting COVID-19 patients, they had isolation rooms and special wards for these patients. One ward for COVID-19 patients, separated from the rest of the hospital, leaving the rest of the hospital safe for everyone else. So every time a COVID-19 patient walks in, they get dedicated nurses to take care and support them.
Safety is our number one priority all the time. This helps to keep not just our staff, but also our patients and the general public safe.
They have doctors that specialize in infectious diseases, separate security 24/7, separate disposable cutlery, and even separate air ventilation systems to make sure even air doesn't go to other parts of the hospital. This separation is vital to keep everyone safe because for all other patients, it's the new norm. Many people still need hospitals, especially when they have worrying symptoms like chest pain, vomiting, or sharp pain in the stomach that need urgent medical attention.
Because of our very strict protocols and safety measures, our hospitals are safe, and that is a fact.
Because everyone, from senior management to doctors to nurses to security guards to chefs, is doing the impossible to keep the hospitals safe for you. So, only if you need urgent medical treatment, stay home, be safe, and keep healthy.
they wealthy, be they meek.
Once as bold and sweet,
Standing firm for all that we should be. We do what's good for banking governance. Learn the rules and give them prominence. Let's make sure of what is truly right. They will be the trusted light. We are the members of the APB, serving all who are in our society.
onwards to the future.
We do ascend with challenges and tests. We shall contend by building on the strength we uphold. With bankers' ethics, we'll be bold. Empowering professionals, we are committed. Since 1988, we stand united. We stand united.
Good morning to you all. Welcome, chief speaker and today's resource person, Dr. Steve, and all participants to this vital session. The APB continues to contribute in numerous ways to uplift the professionalism and is a more vibrant association among the bankers. Having 31 years, having over 31 years history in our association, comprised with more than 2,000 professional bankers of Sri Lanka, and also always assist to sustain the highest standards of professionalism and integrity among the bankers. And also I would like to make few comments about this session. This is indeed a great pleasure and honor to welcome this elite gathering today for this knowledge sharing session conducted by our guest speaker on a timely subject matter that impacts all of us and the society at large, regardless of our country, creed, or professionalism. Given that the entire human race is facing unprecedented challenges due to Covid-19 pandemic, we are fortunate to have a person of such expertise, expertise, Dr. Steve, to share his knowledge with us. Therefore, I kindly invite our Learn membership to actively participate in this webinar and make the most of this session together and share knowledge which would immensely benefit not only to our members but also to their kith and kin. On a final note, I wish to state that all members of the Continuous Professional Development Committee of the Association of Professional Bankers earnestly hope and pray for the dawn of a healthier and secure tomorrow in which each and everyone is safe and well taken care of. Thank you, and may the blessings of the Noble Triple Gem be with you all. Now I kindly invite to our moderator to proceed with this session, Mr. Jeremy, to continue the session and to further moderate this session. Jeremy, over to you.
Right. Thank you very much, Mr. President. Welcome all to this program. Are we seeing the end of the beginning or the beginning of the end? COVID is the most hated and frightening word today, which would send a chill down everyone's spine. With no permanent cure far outside, people around the world are living in fear of this virus, that it can knock at their doorstep at any time. With this, I would invite Terence, who Assistant Manager, Market Development, International Marketing of Parkway Hospitals, to present a few clips on Parkway Hospitals and their services as our co-partner and sponsor of this event today. Parkway Hospitals joining Association of Professional Bankers in organizing this and delivering this webinar on this pertinent subject today of COVID-19. Over to you, Terence.
Good morning, everyone. Well, it's afternoon over here, but good morning, everyone, nevertheless. Allow me to just quickly share my screen.
Good morning.
Okay. Can everyone see my screen?
Yes, Ken.
Okay, allow me to begin. So good morning, everyone. My name is Terence. So thank you for joining us for this webinar. So together with MedConnect and team, we are here to assist our clients in Sri Lanka. Here at Parkway Hospitals, we aim to provide you with world-class care swiftly and affordably by the best team in medicine. As a medical destination, Singapore is a global medical hub with world-class facilities, skilled healthcare professionals, and are the leaders in critical and complex care. Our country is a multicultural place which does not make you feel left out, and we can give you the assurance that our organ transplants and blood supply are some of the safest in the world. Parkway Hospitals is part of IHH Healthcare, a multinational company which has 55,000 employees worldwide, 15,000 licensed beds, 77 hospitals, and are present in 10 countries. Starting from May 2017, all our hospitals have obtained JCI accreditation and maintain it to this day, giving our patients the assurance that we uphold high standards in healthcare practice. In Singapore, Parkway Hospital, has 4 campuses: Mount Elizabeth Hospital, Mount Elizabeth Novena Hospital, Gleneagles Hospital, and Parkway East Hospital. So among these 4 hospitals, we have you covered for any medical specialty. Between our hospitals, we have 15,000 practicing specialists, all of which are senior consultants trained at top institutions, armed with the latest equipment, techniques, and treatment, and adopt a team-based multi-specialty approach to treat our patients. Speaking of latest technology, here is a glimpse of what we have in our radiology department used to quickly and accurately diagnose patients. When we combine the well-trained medical specialists with state-of-the-art equipment, we get clinical excellence. So this is evident in our practice, and we track our outcomes to ensure high standards of quality control. In the graphs here, these show that our hospital has consistently lower rates of infection and readmission compared to other global institutions. As a result, we are proud to say that every year, more than 100,000 foreign patients trust us to give them a successful treatment the first time, every time. As a multi-specialty hospital group, allow me to give you head-to-toe coverage of conditions that give you the best outcomes and quality of life. For cancer treatment, besides radiotherapy and chemotherapy, we offer radiosurgery, linear accelerator treatments. Our specialists can offer minimally invasive surgeries for just about every organ in the body, heart valve replacement without ever cutting open the heart, LVAD implants for end-stage heart failure, robotic partial knee replacements, multi-organ critical care, and last but not least, air evacuation. Location-wise, our hospitals are in the center of the city, easily accessible by taxi and public transport. Mount Elizabeth Hospital is located in the Orchard Shopping District. Mount Elizabeth Novena is located in the Novena area, and Glen Eagles Hospital is located right next to the Singapore Botanic Gardens, so that this is not only convenient for patients, but their caregivers as well. Even in these dark times, Parkway Hospital stands united in our support for our patients in Sri Lanka. We will do everything we can to support you by helping you get medical advice from our doctors, provide medicine delivery options, and help with application for entry waiver into Singapore for medical treatment. Parkway Hospital Singapore has a team based in Sri Lanka ready to provide you with assistance. Dr. Numini is from MedConnect Private Limited and runs a 24-hour assistance center in Colombo. Over to you, Numini, to introduce yourself to our viewers.
Hi, good morning, everyone. Yeah, I'm Dr. Nilmini, working for Mount Elizabeth Hospital, basically Parkway Hospitals Group. Should you need any specialized medical advice from Mount Elizabeth Hospital or any Parkway Hospitals, feel free to contact me. Wishing you good health and happiness. Stay safe. Thank you.
Thank you, Numini. So now I have come to the end of my presentation and hope you will enjoy the rest of the webinar that we have organized for you. Thank you.
Thank you, Terence, for that introduction of the Parkway Hospitals. Now my duty is to invite our presenter today and introduce Dr. Steve Yang. Dr. Steve Yang is a respiratory specialist at Mount Elizabeth Hospital, Singapore and Parkway Hospital, Singapore. Dr. Yang has received his primary medical education at National University of Singapore and received his degree in 1994. And subsequently received training in respiratory medicine and intensive care medicine at the Singapore General Hospital. Dr. Yang further was trained in intensive care medicine and lung disease at the University of Washington Medical Center in Seattle, USA, and is also, to his accreditation, he is a fellow of the Royal College of Physicians. He holds a Bachelor of Medicine, Bachelor of Surgery, Fellow of the American College of Chest Physicians, Fellow of the Academy of Medicine Singapore, and also holds the European Diploma in Intensive Care. Dr. Yang also serves as the chairman of the IRBD, a subcommittee of Singapore Health Centralized International Review Board, and also has published many medical articles and research on lung diseases and published them locally and overseas. And it's my pleasure to hand over proceedings to Dr. Steve Yang to present his views on this COVID area, on the learnings and awareness of how we could know more about this virus and what are the new areas of care that we should be taking and the precautionary measures. Over to you, Dr. Steve.
Thank you all. Good morning. Thank you all for tuning into this discussion and on the latest we have on the COVID. You all can hear me very clearly?
Yeah, correct. Can hear.
Okay.
Loud and clear.
Good. Thank you. So let's start on the topic. Right. So the topic here is we've known COVID we have heard it ad nauseum through the news, through friends, to the media since it's starting in 2019. So right now we are in the 2021, right in the middle of the pandemic. So are we approaching the end or are we just only at the beginning? And so we need to review the data and to look at what the trends are like and how we can plan and prepare for the future. So I'm a pulmonologist and intensivist, and my interest is typically in critical care patients, interstitial lung disease, patients with end-stage lung disease, and research ethics. Now, if we look through the pandemics that we've all had in the past, right, starting in the earliest documentation, tons of pandemics happened around the world, right? But with the latest, of course, besides other than HIV, the last one we had, which caused a great number of deaths, was a Spanish flu. Right? There was a smaller Russian flu here, which we don't have much details on. And of course, we have COVID here. So let's look at the latest pandemic we had, which was the Spanish flu in 1918, 1990. This was actually caused by the influenza virus, which is called also the H1N1, all right? And remember, the first wave started in the US, and of course, there was around the time of World War II, and the soldiers were moving from the US to overseas and interacting with people from overseas, and then they were coming back. So that's where the first wave developed sometime in spring. And then what happened is that the second wave happened when all these other people who were infected went back to their hometowns, and then for the other people from different countries went back to their villages, and that's where they passed the disease around to other people. And that's where the second wave developed in the fall of 1918. And the third wave followed that in the winter of 1918, right? And then basically only the end of 1918 was a pandemic declared more or less over. Then let's look at the next pandemic we had was the 2009 pandemic, again caused by the H1N1 influenza virus. Right, and happened about the same as in the 1918 pandemic. There were about 3 waves, starting from spring, lasting all the way until 1 year later when things finally over and the pandemic was declared over by the WHO. And we look at how the virus panned out for the latest pandemic in 2009. What really stopped the numbers coming down here was actually vaccinations, which started only around about 9 months or 5 months after the pandemic started. They got the vaccines in, people were vaccinated, then actually the pandemic was actually declared over. So let's move into our latest pandemic. We're all quite familiar with the structure of the coronavirus. All right. If we look at the BT, cut in half, we see what happens is that we have the RNA inside, which contains all the genetic material of the virus. And one of the important things we talk about is your spike proteins, which is found on the surface of the virus. And how the spike protein is important is how it enters the cell. So if you look at the origins of different coronavirus infections in the past, remember the SARS in 2003, that was caused by bats transferring to the civet cat. And from the civet cat, it went all the way to humans. Then we know what the MERS infection, also a coronavirus in the Middle East. And again, this transferred to humans was animal to human. But for COVID, they have still not found the medium. People really don't know. Is it bats? Was it the pangolins? Was it some other creature? It's still being unidentified at this point of time. Now, why is it important to identify? It's because we want to avoid and to prepare for future pandemics, because this will not be the last one. So what happens when you meet someone who has COVID and you're unprotected? First of all, the virus enters the respiratory tract, right? From there, it enters the mucous membrane, goes into the lungs and the bloodstream, and that's where you develop symptoms, right? And therefore, you look at this slide, the important thing is what you call your spike proteins. The spike proteins here join to what you call your ACE receptors on your cell surface, allowing the virus to enter the cell, releasing its DNA, and therefore tricking your own cells' proteins to start producing the viral genome. And therefore, a result, from one virus, you create multiple replicas of the virus, and then you release it into the atmosphere by coughing it out. At the same time, the virus starts to damage your body. Right? Now, once you cough out the virus, it can persist for up to 3 days on surfaces, right? If you go marketing, you can stay on plastic for up to 72 hours, hospital beds, even in your trains and all your public transport. And that's where they use this as evidence of infection control, which we will see later. On certain surfaces, it tends to survive shorter. In plastic, this lasts for a much longer time, and therefore infectivity doesn't drop even after a few hours, even in the sunlight, unless someone really cleans off the surface carefully, right? And once you have the virus infection, it stays in you, and you can still continue to spread the virus even up to 37 days, which is almost like 5 weeks, even after your initial test, right? And of course, if you have mild disease, you tend to have shorter days of virus shedding, whereas if you have severe disease requiring hospitalization or ICU stay, then you remain positive for longer periods of time. We know patients who are totally asymptomatic, no fever, no cough, and they are still able to pass disease, but their viral loads were lower. So that's where this is one of the smart things the virus has able to enhance its survival. Now, once you get a virus infection, about 5 days later, you develop symptoms. And from that point of time until death, it can range depending on your age. But on average, earliest 6 days because of overwhelming inflammation or severe oxygen levels, up to even 6 weeks, people have died. And typically, you depend on your age, what's your health status, and the level of care you receive in these patients. Clearly, those below 70 die less. Those who are above 70, they actually die longer. Okay, and those over 70 tend to die faster. Now, in terms of the symptoms, most of the symptoms are typical, whether it's in the US or China, because the variants were different, which we'll discuss later. Most of the symptoms were fever, coughing, breathlessness, fatigue, and you can see the other tests we do. People present with certain raised liver enzymes, which indicate infection, and the rare ones like lack of smell or lack of taste happens, but it's not so common. So we look for the common symptoms in most of the patients. Okay? So nowadays, what happens is that we tend to see patients with less of these symptoms and more of the alternate symptoms like diarrhea, headache, and these are the ones we have to look out for because the virus is changing. And we cannot just look at only the common symptoms. We have to start looking at the rare symptoms because that could be a manifestation of COVID itself. Now, how does COVID affect the lung? When you have infected, what happens is that it enters your cell, and causes an inflammatory reaction. If you have a moderate reaction, what happens is your lungs start producing fluid, which fills up your lung units, and therefore you become breathless and you require supplemental oxygen. When it's severe, your entire lung units all filled with fluid. As a result, you can't even breathe. And in these situations, you have to put on the ventilator. You sometimes need alternative modes of breathing to help improve your oxygen levels. Because if you're not, once you have not enough oxygen in your blood system, the rest of the organs get affected, and you can get you delete into something we call multi-organ dysfunction and eventually multi-organ failure. Now, COVID, unlike the other viruses, has long-term side effects, and this has been shown that at least 80% of these patients have some sort of symptoms long-term. It means even though they're fully recovered from the viral infections, a lot of them have maybe fatigue, headache, memory loss, and this will lead to problems down the road because these are young patients and old patients, and these are patients who are supposed to contribute to the society. And once they have all these symptoms, their effectiveness drops, their contribution to society falls. Therefore, coronavirus is not a current problem, it's going to affect the future in the next few generations. To detect the virus, of course, we have the PCR test, which is your nose swab, usually very strongly seen in the first few weeks of the disease. Sometimes even before you have symptoms, you can actually test for the virus, but how to pick up these patients are very difficult. And of course, you can develop antibody testing, which can be done once your body has formed an immunity to it. And then you can do blood tests to detect for the infection. But these antibody tests cannot be used for the acute infections because you see it takes almost up to 2 weeks after the actual infection to develop antibodies. So in terms of control, where are we now around the world? If we look at the global situation, just updated a few days ago, you can see that the number of cases that happen in the world, almost about 170 million cases, of which 3.5 million have already died, which brings to around maybe 2 to 3%. All right. Now, you can see that happens in waves of disease. The first wave was called wave 1, which started really early, and then there was a break. Following that, wave 2, where number picked up again, and there was intervention, and the numbers dropped. And then there was a third wave. All right, it happened again in this year, and the numbers seem to be dropping. But will it lead to a fourth and fifth wave? We can only guess. Okay? You can see the waves and how affected countries are quite different. It depends on different countries and depends on your location. The big Europe was affected here sometime between September to December. So was the Americas as well. And as well, the Southeast Asia is now picking up in terms of the second wave of infection, or some might even call it the third wave of infection. right? So that's where Southeast Asia is now suffering a pretty bad wave of both cases and deaths at the same time. If you look at different regions, all right, most of them had first wave, second wave, and third waves. Some countries even had the fourth wave happening, right? In Southeast Asia, we were relatively spared until we're hitting a second wave now, which is actually quite devastating. Some areas are not so bad, first wave, second wave, and third wave, and now the numbers have come down quite nicely. This is Sri Lanka. You can see that you had the disease really well controlled from January of last year until end of last year. Then the numbers seem to be spiking with both daily counts as well as testing being done. And you seem to be also in currently like either you could consider a second wave of infection. An important thing to look at this case is not look at the numbers, but you look at the age group. You can see that the majority of patients who are infected by COVID were actually between the 25 to 64, which is relatively the important patients because these are the ones that are contributing to society. These are the patients with the experience, they have the knowledge, and these are the ones that are being affected by COVID. And remember, COVID doesn't stop you, it doesn't stop just when you end the disease. It lingers on and affects you for the next few years. But look at deaths. The deaths were actually strongly above people above 65. So the older people were the ones that were affected by COVID and dying from them. And this is a vulnerable group, which we normally try to protect as much as possible. If you break down into either male or female, the numbers are relatively similar, except in deaths, they tend to occur more in the male group between these ages all the way to 75, but above 80, then the numbers go much higher. Now, case fatality ratio seems to have come down a little bit. Now, case fatality ratio indicates number of deaths compared to number of cases. So initially, the case fatality ratio was really high at the beginning of the disease, but now it seems to have tapered down to around 2%. So if you have COVID, 2% will actually die from the disease, and these will tend to be your older patients and who actually succumb to the infection. And why is that so? Because we have managed to identify important treatments which helps reduce the COVID severity and give supporting care to these patients until they get better. Important thing like blood clotting, we give them venous thromboembolic disease prevention, like clotting, anti-clotting medications. We give them steroids. We give them good nutrition and definitely rest, and adjusting all your immune suppressant medications accordingly. Important thing is early identification of these patients. Identify who are at risk of developing secondary infections, who can develop problems with breathing, and you give them oxygen early, and you actually send them to the intensive care unit early to prevent the disease from actually catching you unawares. The other thing, of course, lots of therapeutics, because we have heard of a lot of drugs that can help in terms of treating COVID once you have them. Dexamethasone, which is first, of course, we heard mentioned, basically reduces the body's response to inflammation and has been shown to improve survival in patients with COVID. We very well know about remdesivir, which works on the replication of the DNA. All right, this is not a cheap drug, but it's shown to be beneficial in some patients with very bad COVID infections. Now, convalescent plasma was used, all right? Basically, these are patients who had COVID. You extract their plasma, you remove the antibodies from them, which are supposed to be good anti-COVID antibodies. You recirculate them into patients who have the current infection, and it helps to reduce the viral load and therefore reducing the inflammation. We all heard about tocilizumab, which works on the IL-6 receptor of the cells and helps to reduce the inflammation. Of course, this is a very strong immune suppressing medication, and that's led to a few other issues in terms of secondary fungal infections, which you've heard of recently. Then these are the trial drugs, antivirals, which actually work on the DNA of the virus, and you have certain enzymes which prevent the replication of the RNA of the virus, and therefore these are helpful in reducing the viral load, and as a result, reducing the severity of infections. Okay, so what are we going to happen next in the next few months? Well, if we do a comparison between the influenza pandemic in 2009 and the current COVID. So we see some similarities, but we see a lot of key differences. Okay, so what happened? One was caused by the influenza virus, and this one has been caused by the coronavirus. So this is the first actual coronavirus pandemic we've actually experienced. Transmission is similar in terms of droplet infection, contaminated surfaces, but that's where it starts to differ. Now we noticed that the H1N1, although contagious, it's actually much less contagious compared to COVID-19. Whereas the COVID-19 is extremely contagious, all right? And you can even be contagious even before you develop symptoms. And it can persist until after you develop symptoms, after you're positive, you remain positive for a long time, okay? Symptoms-wise, fever, chills are quite similar. But more importantly is you look at the age group of people who are affected by the H1N1 and the COVID, and in the influenza, it was a younger patients. But in the COVID-19, they were actually adults over 30. Other key differences you can see is the risk factors. When you were H1N1, all right, these were 65 years old and above, you had more risk of infection. In COVID, 65 years, older, pregnant, underlying health conditions definitely put you at risk. Now, what happened is a big difference is when you had H1N1, most of the patients who died actually died from pneumonia, or we call secondary pneumonia. And as a result, you had bacterial infections, and from there you lead to other organs being damaged. So if you're able to treat the pneumonia, the patients tended to survive. But in COVID-19, pneumonia was not only the problem, the other problem was inflammation. And this is the one that we use dexamethasone to try to reduce inflammation and therefore improving patients. The other thing that causes deaths and a lot of morbidity in patients with COVID are blood clots. Because the COVID is able to affect your O2, your coagulation profile in your system to start producing clots in your body. So patients with COVID have presented with heart attacks, stroke, pulmonary embolism where blood clots go into lungs, leg and vein thrombosis in the leg. And therefore, it's a totally different presentation from the H1N1. The other worry we have about COVID, of course, with lots in the news, is the variants, because you can see from the start of the pandemic, the variants which really caused the pandemic have largely disappeared, whereas new variants develop and become more and more predominant, right? So we talk about variants. Variants happen when the viruses mutate and a mistake occurs in a replication. It's like asking a scribe to copy a book, right? He copies 1 or 2 books, he makes no problems, but you ask him to copy a book 10 times, some mistakes will happen in the replication process, leading to mistakes. As a result, you can add, you can change, or you can delete certain parts of the genetic code. And now, if this mistake improves its survival, causes more infection, then it starts to survive more, and then it starts spreading, and this variant becomes the new predominant variant in the pandemic. And we worry because the ones that are stronger tend to survive. As a result, these mutations can lead to increased infectivity, they become more transmissible, and sometimes leading to severe disease as well. And when do mutations happen? Is when there's high transmission. So when there's a huge pandemic, a rise in lots of numbers in the society, mutations will happen, and that's where the replication process will be increased, and therefore new mutants are resulting from these transmissions. So there's an important need to try to reduce the numbers of COVID in the society to reduce variant production. Now, not all variants are problematic. We worry about variants when they can cause problems, and we call them variants of concern. They mean it transmits more easily, patients become more ill, and basically reduces the effectiveness of your treatment or your vaccines. And that's where the B1617.2 is a concern, because it definitely transmits more easily, definitely causes more severe illness, and there's always a question about whether it reduces the effectivity of your vaccines. Again, you see the trend of how it started in Wuhan was basically the old virus, and has since completely died out by June last year. And now our pandemic is contributed by new strains that have formed, and therefore the primary strain has no longer disappeared. So some people who have had vaccines or immunity against this strain might not have an immunity against a new strain developing. So that's where your innate immunity or immunity which develops after you had COVID might not work. And that's why some patients have a second infection, some even have a third infection. And these infections can be more and more fatal. So do the ways that we see in like H1N1 or in the COVID vaccines, is it due to the virus mutating? Well, not really, actually. And what happens is human behavior is actually a major cause of causing waves. And when you have communities where you don't enhance or don't enforce mask wearing, hand washing, distancing, we notice case rises. And when people who live closer together, they work closely together, and that's where the more spread of the virus occurs. Now, just because this happens, we don't see this effect until even sometimes 8 weeks later. And that's a scary thing, because when you institute a policy, it doesn't mean you see the effects immediately. You see it sometimes happening 2 months later, then you see it then you see the effect of your policies to enhance mask wearing or hand washing. So why is there a lag? Because you see, when your initial exposure, you can wait up to 2 weeks to develop symptoms. And by this point of time, once you have symptoms, you see a doctor, is documented, doesn't mean they log the case in. But what happens during this process, you're passing your virus to other people around you, and they take up to 2 weeks to show symptoms. So only 4 weeks until the initial exposure do a group of patients develop symptoms. And up to 8 weeks later, they pass to other people, do numbers rise. As a result, we can see when you reduce your policies or what happens after you relax your behavior, numbers will rise, and you can only see them sometimes even up to 8 weeks later. And at this point of time, there is a decision to make. Do you institute policy changes? Do you allow things to continue on? So it depends on the government, depends on the local authorities, how they enforce the situation. Because you are at an inflection point, it can get worse or it can get better. So when the best time to detect changes is when you see this rise down here, you have to institute things early, because it takes up to 8 weeks for your policy changes to see the effect. So if you enhance them early, you can see cases do drop. But if you continue to let cases rise and you don't institute policies, cases will rise uncontrollably until you have a huge second wave. And this has been proven in studies. If you look at this city in Manaus in Brazil, when you notice cases first rising here, they started the lockdown, and this happened from middle of March until June. So it took them about 2 months from the initial lockdown to see actual cases dropping. And at this point of time, what happened is that they led to drop in terms of enforcing a policy. They reduced distancing, they allowed things to open, and then a second wave happened again. But fortunately, you detect that there's a slight change down here. They instituted a second lockdown, and therefore the limit of the rise happened. But if you did not enforce a lockdown here, but rather here, then the cases have gone off the scale to a much higher numbers, and then you'd be stuck with a huge problem of control. And because once you have a large number of patients with COVID, you start overwhelming your healthcare services, and your doctors and your healthcare workers will be affected as well. So important is early identification. When numbers are rising, institute aggressive measures early, because if not, things will go out of control. So after all this, we all want to see how the pandemic ends, all right? So what are the ways we can end the pandemic? One is with vaccinations, all right? So you can see worldwide how the pandemic has panned out and how the vaccinations have taken place. So the darker numbers indicate where vaccinations have been aggressively enforced, and we'll examine some of these countries, all right? So vaccines is one of the ways to end the pandemic, but it's not the only way, which I'll show you in the data later. So if you look at the countries which have administered huge numbers of vaccinations, all right, per 100 people. So let's look at Israel, Aruba, Bahrain, just for an example. Now, people code like Israel. They have done huge numbers of vaccinations. They had 1 wave, 2 wave, and since the end of March, they have been having very few cases. So some people have said this is a great example of how vaccines work. But again, we look at other countries, Aruba. They've had 3 waves. Numbers have come down since sometimes in April. But if you look at places like Bahrain, despite such a large number of vaccinations, they are still having cases rising. So vaccination is not the only way to control a pandemic. You have to control behavior as well. Likewise, you look at the countries which have the fewest vaccines done, right? If you look at Nigeria, right, less than 0.1% of the population is vaccinated. And then we look at Vietnam, all right? You see, Nigeria, despite vaccination being not really widespread, numbers have been controlled. So human behavior does contribute to reducing the number of cases. If you look at Vietnam, right, they've had not much cases despite low vaccination until recently cases started to rise. And therefore, sometimes people use this argument that you have to do both behavior and vaccination at the same time to control the virus. Let's look at Sri Lanka. This is, since we are all looking at the data. Sri Lanka is currently in like a bit of a second wave, but I believe they have instituted some changes so that the numbers have started to drop, and hopefully this would improve partly with behavior and partly with vaccination at the same time. Now, vaccines, we have to be clear about the data of vaccines because vaccines will protect you, okay, by allowing you to develop an immune response against the virus. So you don't develop the illness and you have reduced severity. So you don't tax your health services that much, because once you tax the health services, the whole society can collapse. And more importantly, it protects the people around you. So people who cannot take the vaccine, people who have allergic reaction to the vaccine, you are protecting them when you are vaccinated as well. Now, we know all the different types of vaccines. We've heard of all the Pfizer, the Moderna, the Sinovac or Sinopharm and Novavax. They've used different methods to basically try to create a spike protein in the system, allowing your body to form an immunity against these spike proteins. So there are different methods to try to trigger this immune response. So all of them have different ways of how to do that. And we look at what we have is different, like the RNA virus. Basically, the RNA enters a cell, allows the cell to produce the spike proteins, and then you have to take 2 doses. This was one of the first vaccines around the world. You have the viral vectors, which depending how the virus is transmitted, that's where it's the basis of your AstraZeneca or Janssen vaccine. Then you have the whole virus, which is like what the Sinopharm and the Sinovac. These are inactivated viruses. You again need a dosage, which is 2 doses, and have been used in past before with quite successful in like whooping cough, hepatitis A. Now, of course, you have Novavax, which uses protein subtypes. All right. So now, important thing about vaccine is not just how it's done or the dosages. Second thing, we talk about efficacy. Now, effectiveness, efficacy of the vaccine has been touted. So we want to talk about how you qualify, how useful is a vaccine. So these are the estimated effectiveness of different vaccines. So you can see that the Pfizer and the Moderna have a pretty good efficacy, and a bit less for things like the Novavax as well as the AstraZeneca, and then the Sinovac about 50%. Now, that doesn't mean that the Sinovac doesn't work. It's important to see how the trials for these vaccines were done. So you look how a trial is done is that basically you have tens of thousands of people, you divide them into 2 groups. Half they get the vaccine, half them get a placebo. And what happens is that all these patients go in the community, and then at the end of the study, they come back and see how many of them got the coronavirus. Supposing that 85 were vaccinated, all of them got COVID, and basically same as that of a placebo, the efficacy is 0. If a same scenario, all the patients were vaccinated, none of them got COVID, and all the patients who received a placebo, all of them had COVID, then the efficacy is 100%. So what happened in the Pfizer and Moderna is that they put all these patients in the community. 8 of the vaccinated had COVID, and 162 of those who did not receive the vaccine got the disease. So the efficacy was at 95%, which doesn't mean it's going to be effective 95%, which means that your risk of developing the disease drops by 95%. Now, important thing is the vaccine, you cannot just look at a number. Look at the Moderna Pfizer were done mainly in the US before variants developed, before cases peaked. So they looked at the very particular subgroup of patients. You look at things like the Johnson & Johnson, the Sinovac or the Sinopharm, they were done in other countries, Brazil, South Africa, where there were tons of variants. And therefore, if it was still effective against these variants, then they are actually good. But the Pfizer and Moderna were not tested against these variants. So we don't know the data on this until much later. So if you look at the South Africa trial, Johnson & Johnson looked at the efficacy was about 64%. And so for head-to-head trials, you must compare the same group, same part of the world, and exactly the same time, which is practically impossible. So the important thing to note is that vaccines do not eliminate the virus, but you reduce its ability to cause serious illness, and therefore you don't overwhelm your health facilities. And therefore, by reducing the death, reducing the virus infection to just a minor infection, the vaccine has succeeded, regardless of which vaccine you take. Therefore, what you want to do with the vaccine is reduce those with severe and moderate symptoms to a very small number, improve those with symptomatic or mild disease, and therefore resulting in better outcomes for patients. Your vaccine will have succeeded. And that's what we want vaccines to do. And it has worked. You can see how in the US, by starting different vaccines around, the numbers have dropped significantly. So whatever vaccine you have, it is always useful to take that. Okay. Now, important thing we worry about are variants. So people are concerned about whether the vaccine works against variants, and therefore this is sometimes we have against the new B1617.2, which is called the Delta. We don't have any data, although some data shows that some vaccines are effective. This is still needs to be determined. The next thing that will change our behavior, will change the pandemic, is behavior. First of all, we know about masks. Now, not every mask is the same. We have different types of masks, which are the surgical and the N95, which is the most effective in terms of reducing the virus spread. Then you go to those weird ones or your off-cloth ones. Basically, they don't really work. All right, so as well. So stick to what has been tried and tested, because mask efficacy is important. At the same time, how to use a mask, all right? If it's make sure that your nose is tight, if it's an over the nose, and using it for the recommended duration is important. You can't use a mask for 3 or 4 weeks because it would degrade its use, be soiled, and then its efficacy would drop. And you're relying on something that actually doesn't really work. And what happens with a mask is that, first of all, if you mask up, you spread the disease less. And if you're masked up, if someone has coughs in your face, you also absorb less. So definitely you're protecting yourself and you're protecting others when you wear a mask. So it's important to do that. All right. Next thing is policies to reduce intermingling. And that's where we lead to all the different measures. People use school closures, workplace closures, reduce mass gatherings, public transport, and lockdown. You can see these are all the different trials that look at how successful they were. And what happened, all the trials showed that all different methods of social distancing worked. Now let's focus on this last one. Now, why this one was not so effective is looking at the sequence of how they did the lockdown. Most of them, all that started with was school closures, followed by restriction of mass gatherings, and these actually worked in terms of controlling. Then step 2 and step 3 was actually workplace closures, and that led to a reduction in terms of a spread in the public. But in looking at the last study, they started with mass gatherings, so people were still able to go to school, people would still do the public transport or going to work. Then they started with a lockdown, but people still went to school, still people went to work, and then people still use the public transport. So the sequence of how things are done is equally as important as what you do. The other things, of course, we have is your lifestyle. People who smoke, alcohol use, and drugs, these actually reduce your efficacy of your vaccines, as well as reducing your ability to fight the infection. The important thing is sleep and exercise. It's important to try to boost it when you're having the vaccine. Now, related notice on drugs, and we're not talking about your drugs like cocaine or drugs like your ecstasy. Now, some patients who take immune suppressant drugs like steroids or for biologics, what happens when you're on these drugs and you have vaccines? There have been cases around the world that despite vaccination, you don't mount an immune response. And that's worrying because a lot of patients on steroids for whatever reasons, on immune suppressing medications for whatever reason, and if you use these medications and take a vaccine, the vaccine efficacy actually drops. And that's where it is important. The next thing, of course, is your body weight. People who are obese, people who have chronic health issues, these are patients who are more vulnerable to an infection with COVID, and therefore important to try to reduce all this or have it well controlled. Now, vitamin D, although it's a supplement, has been quite touted in a lot of patients with chronically ill in the ICU, and that's reason because they have done some studies to show that if you have a severe vitamin D deficiency, the risk of you getting a severe COVID infection is much higher compared to people who have a good level of vitamin D. Your risk of developing a severe disease is much less. So good to keep up your vitamin D levels if you want to do something to boost your immunity. So are we nearing the end? Sad to say, I don't think so. Now, we know that pandemics will always end. Vaccines play a role, but not a clinically or very significant role. But rather what happens is that we change and the virus changes. Our immune systems will learn to fight off these infections over time. These viruses will transform into a virus which just causes mild illnesses, which means it becomes endemic, which means it becomes part of the viruses that can cause infections around the world. It won't cause a pandemic, but it becomes less severe and less able to transmit to other people. And that's what will likely happen to the COVID-19 virus. So in time, it will join a handful of other viruses that can cause a cold, but not severe enough to cause severe disease or hospitalizations or deaths. All right. The problem is, when will this happen? We will not know, because we're still in the acute phase of the disease, and we use the models from the previous H1N1s. Probably does not apply in our situation because we are still in the midst of vaccination. We are still in the midst of spreads around the world. We have medications that can help treat this viral infections, but we are not there yet in terms of the true effective treatment for the coronavirus. Okay. So what happens? You end up with patients with mild symptoms, and patients may have become ways, but what happens is that we see eventually COVID-19 dying down, except unlike influenza, this is influenza in slow motion. We might see this extended for the next 2 to 3 years, or even 4 to 5 years. It's like a very slow train wreck in slow motion. So this is what will likely happen in the coronavirus. And based on the current trends around the world with all the mutations, we are probably not really at the beginning of the end, but somewhere in the middle. But how long it will be drawn out, it's anyone's guess. The only thing we know, okay, is that this disease has caused lots of deaths, lots of morbidity, caused a lot of social and economic disruptions around the world. And importantly, and a lot of misinformation has been circulated from mass media, from patients with individual opinions. And as a result, there's a lot of confusion and panic and tensions in all the groups because people are hungry for information. And people would like to hear information that whether it's true or not, it's very hard to verify. So if we all work together, both government, individuals, we can end the pandemic together, not as individuals. And in the end, all right, there's always going to be light. It's just a matter of getting through the darkness that surrounds us all at this point of time. Okay, thank you. I'm open to any questions. Anyone has any questions like to ask?
Thank you very much, Dr. Yang, for that elaborative explanation on the COVID situation. I think this have covered a quite extensive area on how and what are the things and the preventive measures that we should be taking on going forward. Just a few questions, Doctor. Now, the most issue is the fear that people have and the worries that the people get stressed out on this COVID. When they hear, the moment they hear COVID, or they are about to be infected, or they are infected, or a family member is infected, people tend to be a lot stressed out. So what is your advice how to keep a healthy mental status or to be stress-free in a situation like that?
Right. So the stress is definitely a big thing we see a patient with COVID infections, whether you're infected with COVID or you heard of people with COVID around you. And we have seen a lot of rise in psychiatric cases. People become anxious, depressed, sometimes even paranoid. Now, the only thing is when you worry about the COVID-19 infection, when we hear about these things, we take the proper precautions. We try to get the vaccination done. We protect ourselves with the mask. We try to social distancing just to protect yourself. But the stress is always come from the unknown. And that's where if you have no protection, you don't social distance, and that's where you become a bit anxious. Second thing to know that there is treatment for COVID. Most of patients will have a very, very mild disease of COVID, so you don't have to worry that it will kill you. If you seek early treatment, you seek early identification, chances are you will survive the COVID infection if you happen to have it. So important thing is to not deny the problem, is to rather seek help and seek the appropriate help and not try untried medications or what you read over the internet. Rather seek proper treatment because that can help you to have the virus treated and receive the proper care, and you'll probably recover. So the stress comes from the unknown, but a lot of what we know about the virus is known. We know how to treat it, we know how to fight it, we know how to identify it. So I think if you hear about this, be reassured that the world is working towards a solution. So you don't have to fear the unknown, but we all fear when it first started out in March 2020, there was a lot of unknown, and therefore stress levels were pretty high by then.
Yeah, thank you, Doctor. Also, Doctor, now with these vaccinations, there are the first dose, the second dose, which have been given. Now, is there specific timelines within the first dose for the second dose? Is it variant with different types of the vaccine categories, or is there a prescribed time frame, whether 4 weeks, 8 weeks, or 10 weeks? Because recently I saw an article in WHO, it says even a period of 6 months would do between the two vaccines. What's your opinion on what is the advice for the audience on that?
Right, that's a very good question. And you see how the trials were conducted was that they actually gave one dose of the vaccine at dose, let's say day 1, and the second dose at day 21. So the study looked at 3 weeks of dosing, and it looked at the antibody levels at the end of the trial, and they found that antibodies level were high. But they only did 3 weeks. They could have done 5 weeks, or they could have done 6 weeks, and the antibody levels could be just as high, except that the trials were not conducted with 3 weeks. Because if you create some with 3 weeks, some with 4 weeks, some with 5 weeks, some with 6 weeks, then people would question why you did a trial of that nature. You have so much subgroups, your trial becomes invalidated. You can't analyze the data. So the trials were only for 3 weeks. But can it work for 6 weeks? People are trying that, and I think it's effective. People have tried even 6 months, like for the Moderna vaccine, they gave them one at day 0, one at day 21, and 6 months later, they tested them. The antibody levels were very high. But were these antibody levels high at week 21 already? We don't know. So we follow the recommendation by the drug companies, but if you do at least have one vaccine, we know it protects you to a certain level. So if you delay the second dose to a slightly later 6 weeks or even 8 weeks, we don't know it could be as effective. That means the antibody levels are still as high as the first dose. It was not, but unfortunately, the trials did not look at this number. But yes, it can be effective. We never looked at it.
Yeah. Also, Doctor, is there now any negative effect when you take the vaccinations that affects the body or our immune system? Because certain people, we have seen that they have had different various types of elements coming out from taking vaccination. So how does is it solely on the individual's immune system, or is it also reactive with both parts, the vaccination and the immune system combining, that has the side effects or whatever that comes out of from the vaccinations?
Yeah.
Any thoughts on?
Good question, tough question to answer, not easy to have the answers. We have heard of a lot of side effects from the vaccination, whether it creates an immune reaction. Of course, we know about allergic reactions, and of course, this is something to the PEG that's found in the Pfizer or the Moderna vaccine, and that can cause an allergic reaction. But can these vaccines cause an immune response in the patient? Yes, it can. I've had patients who had pulmonary embolism. We have heard of patients with heart attack, strokes, a limb, vein, or arterial thrombosis, which means a blood clot forms in the vein or the artery. But are these patients more prone to these in the first place, and the vaccine just tipped them over? We don't really know. But we have heard of these things happening. So when you do a vaccine and these things do happen, is it causal? Possibly. So we should seek treatment for these patients as soon as possible. But I don't really have the answers whether they can. Over YouTube, I've heard myself, a lot of people say it causes spike proteins to go in the bloodstream, and these can cause increased clotting. And yes, it's been proven in and published in fairly important and well-renowned journals that these vaccines can cause an inflammatory state and increase your risk of clotting. So people have to take some precautions. And if your risk you believe to be higher, there are alternative vaccines. If you have approved the Sinovac and the Sinopharm, which recently received WHO approval, because these are inactivated viruses, they might be more suitable for you. So I think these options should be offered to people who are or who may be at risk of developing these clotting or these inflammatory responses.
At the same time, now when there are shortages of vaccine, is there a now a mixture of two different types of doses can be combined and given? There are in the event there are going to be shortages of vaccine due to the long duration from the first dose to the second dose. Is there any test being done that the mixture of A type with B type would be suitable in different environments?
Right. Well, they have not really been studied because all the trials were only with one vaccine type. But of course, with production delays as well as difficulty getting the whole, hands on the second dose, once the first vaccine has been given, if you have only access to a second vaccine, which is totally different, it might be useful to consider that, because what you want is protection. And how these vaccines work in different ways is to produce an immune response in your body to fight against the virus. So they work by different ways how to enhance this immunity. But the vaccines work to try to improve this immunity. And if it does work to improve the immunity, then I think if you cannot get the whole dose on the same vaccine, but one is different, I would still take it, because it will still give you some more measure of protection.
There was another question that had been posted on the Q&A was when you are taking any specific medications for, like there are the common disease elements like the cholesterol, blood pressure, blood glucose, fatty liver and all. Now combining when you take the vaccine and also any specific recommended medication for this type of common elements, then what would be the side effects or how those will be used in terms of recommended medication to overcome or reduce the factors in effects of those kind of elements?
Right. So when you do this sort of vaccination with all these medical issues, these medications itself are trying to control your body environment so that it looks, it is actually in a better state. So if you are taking these medications, you have a disease of like diabetes, high blood pressure, high cholesterol, you can still take the vaccine. It does not lead to you being not able to take the vaccine because you're on all these medications. So you're on these medications, so long as if your blood tests and your disease is well controlled, have the vaccine, because it's better to have the vaccine than not to have the vaccine. Because once you have a chronic illness and you get COVID, the chance of you having a poor outcome is higher.
Another area that was a question that had been raised was patients who are allergic to penicillin type of in the past, taking the vaccinations, would there be any side effects, or how that person should react if they have to take the vaccination when they have a sort of an allergy of for penicillin or that sort of drug that has been given previously or been taken?
Okay, important question. Now, it depends on the type of allergic reaction you had. So different drugs or even foods can cause different type of allergies, from skin rash to swelling around your mouth to swelling of the eyes, or the worst one that we call anaphylaxis, which means your airways become swollen in diameters, you can't breathe. So if your reaction, if your allergic reaction is that sort of reaction that we call anaphylaxis, then the Pfizer and the Moderna one probably may not be suitable for you, because these drugs can cause an allergic reaction. But will it develop? We don't know, but there have been reported cases of allergies developing in patients who have all these known anaphylaxis. So if you do have that, you might want to look for an alternative vaccine like a Sinopharm or a Sinovac, because they use a different method of producing the antibodies. So depends on, to summarize, depends on your allergic reaction. If it's skin rash, should be okay. If it's something like anaphylaxis, drop in your blood pressure, airway narrowing, probably not.
Also, Doctor, it would be nice if you could share some of your experiences in Singapore, how they have been able to control this virus and mitigate the number of deaths, because in Sri Lanka, we see sudden increase of deaths within the recent few days. But what are the things that in a different way has been adapted in Singapore, that some learnings that our Sri Lankans could take from it?
Right. A few methods by the government. First of all, of course, when the first cases were identified, they started doing temperature scanning, then policies on mask wearing. And of course, we also went through a lockdown in March and April last year for 2 months. Then after that, we slowly opened the country to meeting out. So they closed the workplaces, they closed the schools, they closed mass gatherings, people worked from home. But what was important actually was what we call contact tracing. And that's how you identify patients who had COVID, and then you ring fence them and the people around them. So you limit the spread of this virus. So the contact tracing becomes a very important key in terms of preventing further outbreaks, and the key to contact tracing is not just to contact trace, it's also to be able to do the testing and to do rapid testing at the same time. So you have a system of rapid testing, rapid identification, rapid ring fencing. That actually is important in terms of controlling the pandemic, because you can limit the spread of fire. Ends up you have a small blaze, you quickly put it out, you identify other blazes, you put it out, and then basically you limit the spread. Rather than let fires burning uncontrolled, leads to the whole building being burned down. So contact tracing actually formed a big part of the policy of control policy. And that's a policy we don't see. We only hear about news of how they identify patients, but there's a huge team of a few thousand people behind the scenes, which we don't see, calling people, make sure that they are staying from home, make sure they quit quarantine, rapidly testing all these people. Then the second thing is, of course, the people who comply, people who will listen to authorities, who follow the rules. You need to be quarantined, you be quarantined. You need to be tested, we test. If people that insist on flouting the rules, I don't need to wear a mask, I don't want to be tested, I don't want to be quarantined, then defeats the purpose. So these individuals actually cause more harm, not only to themselves, the people around them, and to the pandemic in the whole. So legislation, because these patients were identified, they were fined, they were given heavy sentences, so leads to people complying. And that's the other important thing in terms of controlling. So we need a government which is strong, forceful, making tough decisions that helps to control the spread of the pandemic. In terms of healthcare, once you have adequate healthcare, you basically patients who have non-serious illnesses avoid going to the hospitals, and only patients, and you prepare hospital beds for all these patients who are ill, then they will do that in anticipation. So what they had in the past, they had what we call paper exercises. They would pretend a mass casualty situation in the hospital, that identify patients who can be discharged, how many beds you can free up. So you do the exercises regularly. It helps you to preempt and prepare for the future when a pandemic arises. So preparation also is important.
Thank you, Doctor. A few more questions have been posted. I think I don't know whether you have a few more minutes to spare to take up 2 more questions. One question is, what do you think about the complex therapy? Can it be considered in an effective treatment against COVID-19 using the dioxazine zinc, vitamin D, and the
right. Good question. I mean, there's a lot of information about ivermectin in the news and on zinc and vitamin D3 and doxycycline. I've read about those. And I've looked at the data. It seems to be pretty effective, although mainstream people tend to try and test it. My opinion is when you do medication, I mean, we try to first do no harm. And if this medication is not going to cause major harm to the patients, then if it's worth a try, then we should proceed. Of course, with caution and then with observation. Because if you don't have access to other antivirals, and if these are all that you have, then what's there got to lose?
One more question, Doctor. Now, if a person is with good health and having a good healthy BMI and a good living style, is the vaccination mandatory to be taken, or is it that person can keep away from it, or what's the general ruling on that? Is that everybody should take the vaccinations in every country?
Yeah, so I believe that everyone should have the vaccination, because even though you're healthy, when you take the vaccine, you're not only protecting yourself, you're protecting the people around you. If you have the vaccine. And remember, people who get the COVID infection, even you're healthy, you can still get the COVID infection. And we're not just afraid of the COVID death. We are afraid of the long-term effects of COVID, because there are people who have symptoms that last for months, fatigue, they can't work, they feel tired, they get breathless. And that's what you don't want to happen once you get an infection. So you want to prevent immediate and long-term problems with the virus. Get yourself vaccinated, because it doesn't mean just because you're healthy, you cannot get the virus. This virus doesn't care whether you're healthy or not, it's going to affect you.
Right. So I think we have come to a most valuable session and feedback given by Dr. Steve Young. And on behalf of the Association of Professional Bankers, we sincerely thank the Parkway Hospitals for agreeing to join us and partner in having this vital webinar to educate and create awareness among the membership. And thank you very much, Dr. Steve Young, for your very elaborative and time that you have spent despite your busy schedule to explain about this scenario to all our people and create awareness in Sri Lanka. And of course, to all the participants and my council members and organizing committee, the Continuous Professional Development Committee, thank you very much on behalf of the organizers for attending to this, and all participants for attending. Please stay safe. Thank you very much. Goodbye.
Thank you.
Thank you.
Thank you all.
Thank you very much.
all for joining.
Thank you very much, Dr. Steve, and the chairman and president of the CPDC committee, Mr. Jeremy De Silva, senior vice president, and our all committee members and all participants this vital seminar.
Right.
Thank you all.
Thank you. Bye. Thank you, Terence. Goodbye. Thank you, Dr. Neville.
Thank you.
Thank you.
Thank you. Stay safe for us.